I would like to thank our national as well as our international faculty for sparing their precious time for this shoulder meeting. Before we begin with our session, we have, I would like to ask the audience that please hold your questions till the end of this session, and we'll take questions in the end of this session. So we begin with the first talk, which is by Dr. Naveed Jumman. He's going to talk about basics of cuff repair. Over to Dr. Naveed Jumman.
Hasib, can you hear me?
Yes, 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 sir.
Thank you, Hasib, sir.
Good.
And just let me share this screen, sir. So I think you all can see my presentation.
Yes,
Yes, yes.
very clearly.
And can hear me as well. So actually, I think we are really missing the presentation by Dr. Kamran Bhatt, because I thought the initial discussion of portals will also include arthroscopic setting and management, so I don't have to go through it. So I haven't focused on the steps of the surgery, but basic factors which needs to be considered when you are considering arthroscopic rotator cuff repair. So because obviously we are focusing on arthroscopic repair mainly here. So no disclosures to made. So just to briefly introduce, it's the most common shoulder condition in the USA. More than 70 million patients per year are diagnosed with the cuff tears. 250 to 500,000 cuff repairs are performed each year in the US, and maybe number may be similar in other countries as well, depending on the population. The disease highly correlated with the age. 65% of patients in 70 years and old have cuff pathology. More than 80% in subjects older than 80 years. And if more than 66-year-old with unilateral shoulder, there is 50% likelihood there the pathology may also be present in the other shoulder. The pathology may be bilateral. So brief anatomy, see the cuff consists of, you all know, mainly we are focusing on 4 muscles: supraspinatus, the infraspinatus, teres minor, and the anterior muscle, which is the subscapularis. So briefly, the footprint of the, you can see the supraspinatus footprint in the mediolateral span is almost 7 millimeter, and anterior posterior is almost 13 millimeter. And you can notice that the footprint of this infraspinatus is much larger than the supraspinatus. In mediolateral it is almost 1 centimeter, and in anterior posterior it is almost 2 centimeter. So this is very important to understand anatomically when we are dealing with cuff restoration. So recognizing the direct relationship between normal anatomy and normal biomechanics is the key to understanding how to properly repair disrupted tissue. You can use any technique, open or arthroscopic. So the main mechanism of the cuff is to keep the humerus head, as the Dr. Shah Sahab told, to keep the humerus head centered into the cavity of the glenoid and oppose the forces exerted by the deltoid. So if the cuff is disrupted, so this is how the end result will be visible on X-ray. So the humerus head is not centered in the cavity. So the shoulder can maintain a stable fulcrum of motion only when it maintains balanced force couples in both the condylar and transverse plane. So as you can see in this picture, the force exerted by deltoid is balanced by the force exerted by the infraspinatus and subscapularis inferiorly. And in the transverse plane as well, the force exerted by the subscapularis is balanced by the posterior cuff, that is infraspinatus and teres minor. So any disruption in the cuff, whether anterior, posterior, or superior, will lead to disruption of this fulcrum and obviously loss of active motion. So you need to restore this mechanism when you are talking about cuff repair. So when rotator cuff repair restores the anterior posterior forces, function will be restored even in the presence of a persistent defect in the superior rotator cuff, that is supraspinatus. So this concept is further clarified by, as already mentioned in last presentation, by this big understanding of this mechanism, the rotator cable crescent complex or the suspension bridge analogy. So this rotator cable, you can say it's a thickened portion of the glenohumeral ligament, a centimeter or a half away from the insertion of the or the greater tuberosity. Crescent-like thick structure starting from the posterior to the bicep tendon and almost up to the inferior margin of the infraspinatus. So mainly the forces are transferred through this, you can say a cable, and the crescent is a thin tissue of the remaining tendon which attaches to the bone. So fortunately, the most tears are located in the crescentic area, and the function is mainly performed by the this cable. So the same mechanism can be, you can say, a rotator cuff tear can also be modeled after a suspension bridge. If the ends of the both ends of the bridge or the cable are intact, so the joint can do well despite the presence of a central tear in the supraspinatus. So a brief indications of the surgery, acute traumatic full thickness tears is obviously the absolute indication. You should operate early as possible. And the chronic tear that fail to conservative measures and any full thickness tears in young patients should be treated operatively. And a patient with unremitting pain, especially night pain, loss of activities of daily living, significant loss of strength, patient with bony impingement with failed rehab, and then moderate to massive tears in active or healthy individuals of less than 50 years old, and isolated partial or full thickness tears without relief from the rehab, and they have high probability of success. So these are the few indications of surgery. Timing of surgery should be considered. So you should, routinely we go for 6 weeks of rehab for range of motion, because we think that the studies show the operating on a stiff shoulder with a cuff tear is suboptimal. But obviously waiting for longer has a tissue retraction concerns. So in a study on sheep model, it was shown that the release infraspinatus tendon allowed retract for 40 weeks, and after release, they found muscle atrophy, significant increase in fatty infiltration, and 7-fold poorer elasticity at time of repair. And these changes are irreversible. So waiting for long may not be ideal for outcome when you're talking about cuff repairs. It should be done as early as possible. Surgical management, usually we divide in open, mini-open, arthroscopic. Open is usually not recommended. So I will be mainly focusing on basic principles to understand when you're talking about arthroscopic cuff repair, and maybe a 1 or 2 slide for mini-open, because that's still in, or arthroscopic assisted mini-open, you can say, that is still in use. So the goal is to optimize the biology of tendon to bone healing, and it should be a tension-free repair. There should be high initial fixation strength, and then followed by proper rehabilitation, considering your fixation choice and biology. So what is the most important when you are considering the arthroscopic cuff repair? The most important principle is to see the tear and reach the tear. So for seeing the tear, that involves controlling bleeding. Controlling bleeding. Sorry.
Please continue.
Okay, so for seeing the tear, most important factor is the controlling of the bleeding, which requires a thorough understanding of fluid mechanics and the turbulence control. So the 4 main things which you consider for controlling the bleeding are the patient's blood pressure. So what we usually do in a patient without comorbids in wheelchair position, you try to keep systolic pressure between 90 to 100. But obviously, when you are planning arthroscopic cuff surgery, especially in wheelchair position, and you are planning a relatively hypotensive systolic pressure between 90 to 100, you need to inform your anesthetist before, because there is chances of cerebral hypoperfusion if you go too much, if you lower too much systolic blood pressure. So, and then also pump pressure is important. Usually between 60 millimeters of mercury for a brief period. You can, to control bleeding, you can increase up to 75 for maybe 10 to 15 minutes, but not longer than that. Rate of flow is important, and then most important factor, the turbulence within the system, which is a relatively underestimated factor, but it's very important. So the Bernoulli effect is when you have the turbulence usually occurs when there is too much outflow of fluid from the different ports which you have created. Too many flow coming out of the ports suck the blood from out of the capillary. So this is known as the Bernoulli effect. So what happens, even if you increase the pump pressure or even if you increase the flow, this will may worsen this effect instead of controlling the bleeding. Now, obviously, you cannot chase all the bleeders. It will be more difficult. So the simple mechanism is to stop the outflow. You can maybe on a smaller step incisions, you can just put your hand, or your assistant can put your hand, and you try to control the outflow to reduce the turbulence to control the bleeding. And even when you are, the bleeding may restart or occur when you're using the shaver. So what, just I'm describing a brief technique what I saw with the Dr. Burkhardt, what he used to do when using the shaver. He was calling his assistant to intermittently clamp the, because obviously we don't have that kind of shavers which do intermittent suction. So when you start the suction of the shaver, it is continuous. So to stop the bleeding, his assistant used to intermittently clamp the outflow pipe of the shaver to release the suction and start and stop again. So he don't have to do it again and again himself. Just one technique to show to reduce the bleeding while you are shaving. So second step is reaching the tear. Obviously, to reach the tear, the surgeon must be familiar with all the variety of portals, including different accessory portals. Just for example, this is a small crescent tear. How you can see from the posterior portal, and then how you can see it is better visualized through the lateral portal. So a surgeon must use different portals based on the cuff anatomy diagnosed on your initial arthroscopy. So, and then obviously you are planning to repair the tear arthroscopically. So mainly historically tear patterns are divided into 4 groups: crescent shaped, U-shaped, then L-shaped and reverse L-shaped, and then obviously massive contracted immobilized tears, and then they have different morphology as well. So crescent shaped tears look like this, and these are more the relatively common tears, 40% of full thickness tears of the posterior superior cuff. And why it is important to recognize, obviously because they are relatively small tears, and they are more freely mobile in medial to lateral position, and you can repair them easily even with 1 or 2 anchors. And the second group is the U-shaped tears, approximately 15% of all full thickness tears of the posterior superior cuff. And it's important to differentiate this tear from the crescent tear because of different mechanism in the repair involved. So the apex is relatively more medial. Maybe you can see the apex of the tear is more medial to the glenoid labrum. So this obviously you cannot just bring this apex to the bone. It will create too much tension on the your repair, and obviously it will fail. So you need to have a tension-free repair. So the best way to repair this kind of tear is to do side-to-side repair first, and then you can see the remaining ends of the end suture with the bone to achieve transosseous repair. Then the 30% of tears are the L-shaped or reverse L-shaped. L-shaped are more common, and this is essentially a kind of U-shaped tear, but one cuff is one arm of the L is U is not mobile, that is mobile, and in a U-shaped tear, side-to-side repair, and then remaining portion is repaired with the cuff. And obviously, in sometimes in chronic L-shaped tears, this margin may retract posteriorly. If that retracts posteriorly, then you have to bring it closer and with the techniques and do this kind of repair. And then massive tears, they have different morphology. It could be a massive longitudinal tears or a massive crescent tear like this, and you need different methods of releasing. It include the anterior release, the posterior release, mobilization, and side-to-side repair, internal. So lots of different methods to mobilize these kind of tears. That include the capsular release, the anterior posterior slide, and side-to-side repair. So anterior
Dr. Naveed, we can't hear you.
sorry, I think it was disconnected. So I don't know from which slide you did not.
Okay, this current slide. It's the current slide.
Okay. So the mobilization of the massive cuff tears include the capsular release, the interval slide of the anterior posterior type, and the side-to-side repair. So there are different methods. So for these kind of tears, anterior slide alone may give you 1 to 2 more additional centimeter of the excursion to bring the tendon to the bone. And when you are doing the double interval slide, that is anterior posterior, this may give up to 5 centimeter of additional lateral mobility of both the SSP and the ISP. So with these techniques, what the Dr. Burkhardt has shown is in a study that obviously it's a tertiary. He has a tertiary care referral center, and he says more than 90% of tears belong to first 3 categories. That is simple crescent, U-shaped, and L-shaped. So only less than 10% of the rotator cuff in that kind of setup are massive tears. And with these kind of interventions with double slide and side to side repair, even those tears which are previously labeled as unrepairable can be repaired with good outcome. So now coming to the biomechanics of rotator cuff fixation. So classically, obviously, when we were doing open repairs, when the two not much anchors were developed, we were doing transosseous repairs. So the studies conducted on cyclic loading of these methods have shown that the in less cycles of the loads, these repairs were failing from the bone side. The sutures were cutting through the bone. So this problem was, this weakness was overcome when the suture anchors were invented. The suture anchors were tolerating more cyclic loading, but obviously they were failing, but not from the bone, but from the anchor and the tendon junction. So this problem was obviously then relieved by the other studies which show that if you increase the number of anchors, if you increase the fixation point, you can prevent that problem as well. So the doubling the number of fixation points of suture to tendon will reduce the load in each suture by 50%. So obviously then you also need to have the optimized pull-out strength of the anchor as well. So the angle is important to which you are putting the anchor. The pull-out angle, or also known as the deadman angle, which is the angle of insertion of the suture anchor, and the tension reduction angle, both should be less than 45 degrees. So as shown in this picture. Suture abrasion is an issue. Suture abrasion can occur at the bone tendon, bone suture interface, or anchor suture interface, or even when you are sliding the knot, or the suture is sliding into the eyelid. So the studies have shown that the metal anchors demonstrate markedly more suture abrasion than the polymer biodegradable angle. So that's why we now prefer bioabsorbable or degradable anchors. Then the final issue is the knot security. So knot security and loop security. So knot security is the effectiveness of the knot at resisting slippage when load is applied, and the loop security is the ability to maintain a tight suture loop around tissue as the knot is tied. So you can see very well in these two pictures, even if your knot is very tight, if your loop is not tight, you will not achieve the desired outcome. So your repair might slip again, even if your knot is tight. So the studies have shown that this kind of knot, the best combination of knot security and loop security, is the arthroscopic surgeon's knot, which is a static non-sliding knot. So three loops followed by alternate half hitches. So the problem is that this is a non-sliding knot, and you need to have some special instrument to apply this knot arthroscopically, which is a device, a double barrel device introduced by arthritis, known as the surgeon's sixth finger. So even you can achieve this kind of knot with the sliding knot as well. But again, you need to, when you are sliding the knot, you need to fix your sliding loop with some instrument or somehow before you apply half hitches to make the knot more secure. So now coming to the next step, the fixation strategy. So we know what things you should consider when you are applying the anchors, and transosseous was obviously happening in the past. Now we have suture anchors. So initially started with the single row repair. Now we are going towards the double row repair, because we know there are studies which are showing double row may be more better. And then there are some modifications in the double row repair which are known as the transosseous equivalent. So they are giving the same kind of results. So double row repairs are biomechanically more stronger and less gap formations. So there are studies in the past which are showing there is no difference in the clinical outcome, but then there are recent studies which are showing the retear rate is reduced when you are doing the double row repair. So this
Dr.
is just a
Naveed, please,
study
we
showing.
are short of time, so please, can you please wind up this? Yes,
I think
please.
maybe only few
Okay,
slides.
okay.
Main presentation is only few
Okay.
slides, so I will just. So you can see footprint restoration when you are doing the transosseous repair versus single row and double row repair. So double row repair has equivalent footprint restoration as when you are comparing it with the single row or transosseous repair. The same here. So double row repair, but if you are doing a transosseous equivalent double row repair with this speed bridge mechanism, it has more footprint restoration. So also it improves the load sharing. So blood flow is also maintained when you are doing a speed bridge technique. You are maintaining the blood flow into the lateral border of the cuff. The rotator cuff footprint may be completely reestablished arthroscopically by means of a double row suture anchor repair, assuming that there is enough lateral excretion of tendon to allow this. So these are the some. I'm just going rapidly through it. So there is a study which are comparing single row versus double row suture bridge technique, minimum 2-year follow-up, a higher tendon healing rate in suture bridge group compared with the single row group, and could not demonstrate the difference in outcomes, but they believe that the tendon is healed. That means it will show superior clinical outcomes. So just briefly, this one slide I'm showing this tape. So I thought this may have been covered by Dr. Kamran, but he did not do it. So you can go with interskin block, or you can go with general anesthesia. You should uh, consider the pump pressure, mindful of blood pressure. The positioning could be wheelchair. I do mostly in wheelchair. It can be lateral, portals and cannula as per your convenience. Obviously start with the anterior, then go posterior, then lateral, anterior, posterior based on the cuff pathology. You need to treat the accessory pathology as well. Especially you should not forget to see the subscapulars. So it's very important to see the subscapulars and do it before before doing supraspinatus, because subscape has a more tight space if you repair the supraspinatus first. So prepare the footprint. Tear pattern recognition is important. Then release, mobilize the tendon, and then do the margin convergence is available. So these are just brief anatomy to make the portals. And then 2 slides for mini oper. I mean, what I do most of these steps, debridement and recognition arthroscopically. If I think that the time has too much time has passed, the swelling developed, or I'm not able to finish the arthroscopically. So instead of following some specific incision landmarks, I just pass the needle through the center of the tendon and then follow the needle with a 5 centimeter incision to do it arthroscopically assisted or mini open. So it has a really, you don't need to remove the biceps, you just remove the deltoid, but just split it and it preserves the deltoid just like a normal thing. So the factor influencing the outcome will be probably discussed in the next talk. So to conclude, the rotator cuff repair results in reliable pain relief and return of function. Transosseous restores anatomic footprint and stronger biomechanically. Patients with healed tendon demonstrated superior clinical outcomes, and then obviously anatomic repairs matters instead of the other augments. Thank you.
Okay, thank you, Dr. Naveed, for this extensive talk. And we're going to take questions in the end of this session. Now, I would like to invite Professor Gamal Morsi. He is a renowned shoulder surgeon in Egypt, working as the head of department sports unit, Alexandria University. So he's going to talk about a special repair, star repair for rotator cuff tears. So over to Professor Gamal Morsi.
Yeah, good morning, everybody. Professor Mohammed Morsi from Alexandria, Egypt. I'm very happy to share with you this nice shoulder meeting. My talk today is about something new in rotator cuff repair. It's called star repair, which will be published next month in the Orthopedic Journal of Sports Medicine for large and massive cuff tears. Here I work in the Alexandria Orthopedic University Hospital. It's about more than 500 orthopedic beds. One of the biggest hospitals in the Middle East. Can I ask the participants to mute the mic?
Dr. Munawar, please, can you mute the mic of other participants so we can hear him clearly?
Firstly, as we just heard, that the arthroscopic approach to the rotator cuff repair has become the standard practice for many surgeons. Why? Because excellent visualization with less post-operative pain, less morbidity. As we just heard, that the types of cuff tears range from partial tear, small tear, medium, large, massive, or irreparable tears. And the main focus and the main problem is regarding the large and massive tears. So actually, the large and massive tears are true challenge with an endless debate. Many surgeons favor only simple debridement and subacromial decompression, but the majority of these tears have now been treated successfully with arthroscopic repair. But you have to choose the optimal repair strategy, as the retear rates may reach up to 20%. The repair of such tears started with single row repair. However, they found that recurrence up to 94%, with overall repair rate of about 25% in the single row group. And the imaging proves that retear of any type in the single row repair group. Then came the idea of doing the arthroscopic double row techniques or its modification with suture bridge technique. However, they found that it is difficult to get the lateral portion of the cuff into an anatomic position that results in limited rotator cuff footprint contact area. As the medial row anchors are tight, the cuff is pulled and punched medially. And this is the problem of doing the double row. And with time, they discovered the Retear Patterns is the type 2 retear where the medial anchor fails and the whole construct in sequence fails. Another study by Yakamoto reported failure at the medial row anchors with the sutures and not pulling through the tendon, causing impingement. Another study published in the...
Yes, sir, we should start.
Yeah. So to continue that, the main problem is the type 2 retear, which is a failure at the medial side of the repair. And this is a study that showed that the repair technique had a significant impact on the estimated incidence rate. And they found that with double row and suture bridge techniques, there is an increased risk of medial cuff failure. So modification in both techniques can help to decrease that risk. Another study with arthroscopic double row repair for large and massive tears showed that the repair rates of 10 to 30%, with higher rates, especially in those with large to massive tears. So again, more effective repair strategy is needed. So what is the solution? The idea is to maximize the rotator cuff footprint contact area that will improve the healing potential. So this may be the need for a third row of fixation between the medial and lateral rows that tied before tying the medial anchors. And this is first published in 2012 by Roger Strander, that did evaluation of footprint contact area and pressure using a triple row modification of the suture bridge technique. And he measures the contact pressure and contact surface area. And he found that the average contact surface area was significantly greater in the triple row group. And the average contact pressure also higher in the triple row repair, with no statistical difference between the double row and the suture bridge group. So the triple row has more contact pressure and more contact surface area. And also biomechanically, they found that the triple row repairs resulted in a smaller gap formation, higher ultimate failure loads, fewer instances of tendon re-tearing at the sutures, and highly secured footprint. So from the configuration, this is the actual double row that you put anchors in the medial side, anchor on the lateral side, and both are knotted anchors. Or the transosseous equivalent, or the suture bridge technique, that you put anchors on the medial side and using the sutures of such anchors in a knotless one to put it in the lateral aspect to compress the cuff in between. Or the triple row technique, that you put anchors on the medial, anchor in the middle, and anchors on the lateral. But in this configuration, you can realize that the middle anchor is separate than the both rows. So diagrammatically, the double row, you have medial and middle anchors. In the suture bridge, you have medial and lateral anchors. But with triple row, you have both concepts, medial, middle, and lateral row. This is the idea of the triple row technique. So what is the advantage of the triple row? It has a triple effect. It has the advantage of the double row that you anatomically restore the footprint. It has also, with the suture bridge, that you have a better compression. So with the actual double row, you have an anatomical footprint restoration. With the suture bridge, you have a better compression. But with the triple row, you have the three effects. the advantage of the double row with anatomical restoration of the footprint, the advantage of the suture bridge technique with better contact pressure, and the unique feature is the tension-free repair, because you repair, as we will say now, we'll see in the coming slides, that you have the tension-free repair, and now you stay in the summit of the pyramid. This was the triple row, but our modification here that we'll publish next month came from our Alexandria University is the star repair. You have the triple row, but the main advantage that we link the middle anchor to also to the lateral suture. Notice it is separate as a triple row, but we linked also to the lateral row in the form of a star-shaped repair. So we start first the technique by putting the medial anchors and passing all the 4 strands from each anchor into the cuff. Then inserting the middle anchor and passing only just 2 strands from the middle anchor. Then tying the middle anchor first in order to have a tension-free repair, and finally tying the middle anchors and taking the sutures of the middle anchor with one of the middle anchor into a lateral knotless anchor like this, giving the configuration of the star shape. So you have a medial, middle, and lateral row. So this is an example of a case of a massive cuff tear and the tendon retracted at the level of the head of the humerus or a little bit near to the glenoid. And this is the video demonstration of the case. It is the right shoulder looking from inside the joint. First, you recognize the tear, and then inserting the instruments from the lateral portal. We are working in a beach chair position, doing mobilization of the tendon, preparing the footprint, and then check the mobility of the tendon, check the biceps because you can see the fraying of the biceps, making some decortication, and then going back to the subacromial space, doing subacromial decompression, and shifting the scope to the lateral portal and the instruments posteriorly to look for the configuration of the tear. As you can see how the tear massive is, you can see. And then first inserting the anteromedial anchor, just lateral to the articular cartilage of the head, and passing the sutures, the 4 sutures through the cuff. And in most of the cases, I usually do biceps tenodesis, penetrating the biceps also. And after passing the suture through the biceps, I do biceps tenotomy, cutting of the remaining of the biceps, and then putting the posteromedial anchor, again posterior and just lateral to the articular surface, and using the suture passer instrument to penetrate the cuff. You can see the delamination of the cuff, and taking the suture one by one, 1 centimeter apart from each other, passing through the cuff and penetrating the superficial layer, and in one of the sutures, the deep layer also. So you can see here passing the sutures. And then after passing all of the medial anchors, I inserted the middle anchor. You can see here at the tip of the greater tuberosity, in the middle of the tear, then using the suture passer instrument to pass 1 color from each suture thread. And this is for retraction, for traction, and bringing the tendon back to the footprint. And you can see here the both suture colors, doing the knot from outside, pushing inside. This is a very important step that will allow the tendon to be back to the footprint. And after closure of the cuff on the lateral aspect, I close the medial sutures, the mattress sutures, without any tension because already the cuff in the place. Then finally taking the limbs from the medial and middle anchors, putting in with the knotless anchors in the lateral row, taking the 3 sutures from 2 from the medial, 1 from the middle, and putting it into the lateral footprint and closure of the defect. And this is the final view looking from the subacromial, from the lateral portal. You can see complete closure of the cuff defect, and these are the 2 knotless anchors, closing the cuff defect and holding the tendon back to the position. And after checking the repair integrity from the subacromial space, I usually go through intra-articular to check that the cuff is back into position with complete coverage of the footprint. So this is before the repair. You can see the tear, how massive the tear, and this is the final repair with the star modification of the triple row technique. This is the post-operative MRI. You can see the triple row of the repair, and you can see how the supraspinatus and the cuff and infraspinatus back to their position. So why star repair is different than the triple row? Because in the original triple row, as I just said, once the medial anchors fails like this, then the lateral row has no effect, and the whole construct will depend only on the middle anchor. But in our star repair, we link the middle row to the lateral row. So in case of failure, type 2 failure, which is common, occurs, then the construct will act as a double row, not as a single row like the previous triple row technique. So the advantages of the star repair is or the anatomic reduction of the rotator cuff back to the greater tuberosity, decrease the dog ear formation, resulting in greater contact area, greater contact pressure when compared with the standard suture bridge, more points of fixation, improved visualization when tying the medial row knots, and highly secured footprint. So it ensures more effective repair strategy. The disadvantages, it is more anchors and more or less some little operative increase in the operative time. So if we summarize, dealing with cuff tears, if you have partial, small or medium tears, you have the option of doing single row or double row technique. But with large and massive tears, it was said that the double row has good results, but nowadays the triple row may replace the double row, and even with the star repair, is you can guarantee an effective repair. So I think large and massive tear need an extra row. So try the Big Mac. This is the old triple row, but nowadays we have the star repair. It's the Grand Mac. Thank you very much. And if there is any inquiry, here is my email. You can send me anytime, and I'm very happy to be with us, with you here in the such meeting. Thank you very much.
Thank you. Thank you. I would like the audience, if there's any question, you can ask Dr. Morsi now because he has to leave. So if there are any queries, you can ask him now.
I'll ask a question, G.
Yes, yes.
Okay, so thank you very much. Very nice presentation. Makes sense. Do you do the, well, I've got a couple of questions. Do you do the middle repair first and then the other repair? Is that how you do it?
Again, please, you ask about the middle anchor?
Yes, the middle anchor you do first before you do the double row later on. Is that correct?
Yeah. I started first with the medial row with the 2 anchors, passing all the 4 threads.
Okay.
And then putting the middle row. This is the reduction anchor. I say it a reduction anchor because you put the middle anchor at the lateral edge at the tip of the footprint. Then you pass just simple sutures. It is double loaded. I use 1 suture from each color, and then do reduction at this stage. So to ensure that the cuff is sprained without any tension at the footprint, and then closing the medial row, and finally taking the sutures from the medial and middle together into the lateral row.
Okay. So my experience is slightly different. You know, I need to know the quality of the tendon. All these repairs are great, but in my hands, I'm not sure what the experience of others is. In my hands, if the quality of the cuff is not very good, then you can do a fantastic repair. However, the tear will not happen at where you repaired it, but the tear will happen at somewhere else. So I think big tears in my hands don't do well. So after they go beyond a certain limit, I have 5 centimeters difference between the tuberosity to the margin of the tendon, or 3 centimeter across. If I get into that stage, then my repair doesn't work, and then I have to look for something else. I don't know what the experience of everybody else is yet.
Yeah, the first thing is to have to look to the quality of the tendon. So if it is repairable according to the definition regarding the retraction and the fatty infiltration, and indeed the tendon with the retraction and the MRI, you can, with the new mobilization techniques, bring it back to the footprint more than you expect. But if it is fatty, grade 3 or 4 fatty infiltration, so it will not heal with any technique, even with the single or double or triple row. So the first, you have to identify it is repairable. Once it is repairable, I advise you to use the star or triple row. And there is the study will be published next month. It's about more than 50 cases. We did the outcomes with the star repair, and they have a really marvelous results, because the patient starts with pseudo-paralytic arm and ends with complete elevation of the arm. And you have a very surgeon confidence after the repair, because you can bring the cuff back to again. And the important thing, after doing your mobilization, you use, as you saw in the video, the instruments that the magic forceps that you pull the cuff and ensure that it brings back to the footprint. But with the triple row or the star repair, you ensure that there is a tension free, there is increased contact area, there is increased contact pressure, and at the end, increased healing rate.
Very good, thank you.
Thank you very much.
Any other question, please?
Naseem, I had a quick one. Thank you very much, Professor Lucy. It's very kind of you. Can I just ask, the Gotelier grading with these 50 patients that you had, what was the overall, were they all grade 3 and above, or what was the Gotelier grading in terms of?
Yeah, we include till grade 3. Grade 4, we are excluded from the study, but sometimes you have a massive tear acutely. So the tendon quality is good. It's grade 1 or 2. And with the degeneration, you have sometimes 2 or 3. But more than grade 3 with complete fatty, more than fatty infiltration, so the fat will not contract and will not, the tendon will not heal.
And I noticed you did an MRI showing the suture the anchor placement post-op. Did you do MRI on all these 50 patients post-op?
No.
Okay.
Because most of them did well, so they refuse. They don't have, they ask why to do MRI again. But I already have some cases with MRI follow-up, because some of them want to check the repair. Some of them have some pain. So I use this opportunity to check my repair also.
And do you find change in the muscle atrophy?
Surprisingly, I found some improvement in the muscle. This is not proved theoretically, but I found this, that maybe because in the beginning, the pre-operative MRI, you see the cut of the muscles at the torn muscles, that there is no muscle quality of tissue. But when the muscle came back to the original position, then you can see some improvement. And this also depends about the age of the patient and the occupation. But the overall result, there is significant improvement. Because that made me, nowadays, any massive cuff tear, large or massive cuff tear, I use the star repair, because it you end with a good result. At the operation, you have surgeon confidence that you did a very good repair, and the patient are happy at the end of the follow-up.
Great. Thank you very much, sir.
Thank you, sir.
Yeah, thank you, Dr. One final comment. You know, I agree that the Gotelier classification is main thing that I do before I would like to repair or not. But I do a very Daisy style, test. So I take the grabber and grab the cuff, And if it starts disintegrating into my gravel, then I know that it is irreparable. But that is not evidence-based. Anyway, thank you. Can we continue?
Thank you very much.
Okay, thank you, Dr. Morsi. It's the first time Professor Gamal Morsi is here in this Pakistani forum, and welcome, sir. And
it's my pleasure. Thank you very much.
Yes. Thank you, sir. Thank you, sir.
Thank you very much, and I apologize you that I have to leave because I have a clinic now. It was my pleasure, and looking forward to continue with cooperation. And I also thank you, Hasib. You were great when you were here. Thank you all, and see you soon, inshallah. Assalamu alaikum.
Now I would like to invite Professor Tariq Zaman. He's going to talk about the predictors of cuff repair failure. So please, over to Professor Tariq Zaman.
Assalamu alaikum, Hasib, everybody. I'm not a professor, I have to say, but I'm glad to be given the title.
But you look like a professor.
I have to put my glasses on then. So. First of all, can everybody see my screen?
Yes, sir.
Okay, so you can see that? Yeah, okay. Right, Assalamu alaikum. Thank you very much, Hasib, for the introduction. First of all, can't let this pass without saying an Azadi Mubarak. And I think I just realized we had an Egyptian amongst us, so I was going to translate this, but now everybody should be able to read this and see that it's still work in progress. Can you see the screen?
Yes.
Okay. So look, just a basic thing. It's a common problem in general practice. Not just going to quickly go through this. A lot of this has been covered, but I'll come to my point, which was really predicting rotator cuff failure. We all know the basic anatomy. This is a bird's eye view showing that the cuff is very important. And as Manavra showed, the hand holding the head, it's an important dynamic stabilizer. There's no way that these small cuff muscles will actually lift the arm. All that is done by the big boys outside, the deltoids and the pecs and all the others. So the cuff is an important dynamic stabilizer, and that's something we need to keep in mind. There's a lot of problems going on in this small space. We have the subacromial spur, which is thought to be part of the extrinsic reason why cuff tears happen. But as we've seen, the tendon passes beneath the acromion, and the space can become narrowed. But there are definitely intrinsic factors at play as well. And these are some of the things that we see, but perhaps we're not seeing the whole thing. Picking the winners. I mean, we saw a very good talk there by Professor Morsi, and we now have the ability to repair very large tears. I think the last decade and a half or 2 decades was spent by the companies on improving the equipment they supplied us. And I think they've done a good job in working in collaboration with the surgeons to do that. However, we need to not lose sight of the fact that the ultimately success will depend on the quality of the tissue. And I think what Manova was saying there about the flexibility of the tissue we're trying to repair is important. Muscle wasting is very important. And there was work done by Schneeberger et al. In Gerber's Institute, where they showed in sheep model that tears over 4 years old, where the muscle wasting had become chronic, if you did even repair that tendon and did it well, you still had a very low chance of the repair ultimately being successful in a very high retear date. So we can do all this. We discharge on the same day. They wear a sling for comfort. We do little holes, and we can do lots and lots of things. But there's really a lot of little information regarding what's happening in the other shoulder, which would tell us probably something about the natural history of the cuff and what the tissue that we're dealing with. You would never, I mean, the comparison I use when I'm talking to my juniors, I say, look, you would never you would never be basically repairing. Can you everything okay?
Yes.
Yes, sorry. So you would never try to repair the bowel if you were a general surgeon, if you were suspicious about the blood flow to the tissue that you're going to try to repair. But we orthopods, because we're not trying to channel feces or other stuff that can basically kill us, we're a bit more cavalier about the tissue that we repair, and we think we can do it with impunity. But of course, surgery is a big undertaking for the patient. There was a study by Yamaguchi et al. In 2003, and they looked at the morphology and incidence of cuff disease. It's important to understand the basic problem before we try to deal with it. So they looked at nearly 600 patients, and actually out of those, a third nearly had bilateral intact cuffs, almost a third had unilateral tears, and another third, nicely split up, had bilateral tears. And they looked at associations with age, cuff thickness, tear size, and symptoms were tested for association. So not surprisingly, cuff disease increased with average age. At 48.7, there was no tear, but unilateral tears started in the next decade. And in the third decade, in the late 60s, they were showing a bilateral tear. So after the age of 66, and that was quite significant, there was a 50% likelihood of bilateral tear. So we're building up a basic picture of the problem that we're dealing with. If you have a patient with a full tear on the symptomatic side, now so tear with symptoms, there was a 35% incidence of a tear on the other side, but all asymptomatic. But if you had an asymptomatic or partial tear, there was only a 5% incidence maximum of a contralateral tear. So having a tear and being symptomatic with it increases your risk of having a tear on the other side as well. With bilateral tears, again, not surprisingly, the symptomatic side was larger. 65% of the painful tears were on the dominant side, and for intact cuff thickness equal 4.7 millimeters was not affected by age, gender, or symptoms. So this then leads one to surmise that cuff disease is intrinsic. However, the association of hand dominance and increased tear size indicate that intrinsic factors may be important in the development of pain. This was a study that we published after I started the study when I was a fellow at the Reading Shoulder Unit, and it was published in JBJS in 2008. And we looked at the blood flow in vivo using laser Doppler flow dopplerimetry, which is basically a small probe passed through a spinal needle while we're doing the arthroscopy. And we looked at blood flow in different points. And what we used instability patients, younger patients group, as a control. And we found that the area of loss of blood flow 1 centimeter away from the insertion of the cuff was actually something that's established over time. It's not something we're born with. So people in their 20s had no drop off in blood flow 1 centimeter away from the insertion of the cuff, and this was a developmental thing. So these are, the cuff tears that we see in ultrasound when we're in there. And what do we do? Well, we repair them. I mean, we've seen some good pictures there from the professor. I won't necessarily repeat those, but there are lots of different things we've done. But I think we need to start being a bit more clever and look at the tissue we're dealing with. So this is one paper that was published in 2017, and Andy Carr from the Oxford group looked at this, and they repaired 32 patients. Well, they repaired 50 odd patients, but they had 32 for follow-up. And they found that the overall, and these were 8 small tears, remember? So we're not talking about the massive ones that Professor Morsey talked about, but even in these, and in the UK, in the NHS, 9,000 repairs of the rotator cuff are done annually at a cost of £6,650 each. And that's about 60 million to the taxpayer every year. So a significant outlay, not massive, but a significant outlay. And that's just in the NHS. Of the 32 patients in this mixed bag, the overall re-rupture rate was 46%. So half of them failed. We're not talking about single row, double row, triple row, but these are up and down the country, tears that had been done. This is a multi-location study. Small and medium rare tears had a re-rupture rate of 35%, and 60% of the large and massive tears suffered a re-rupture. But when they looked at the histological features and repair integrity, not surprisingly, cuff repairs which remained intact demonstrated a greater reparative response in terms of increased fibroblast cellularity, cell proliferation, and thickened synovial membrane. The larger tears that did remain intact also showed, not surprisingly, a high degree of vascularity and a significant inflammatory component. So the key message here, and it's not rocket science, appears to be that the tissue must have intrinsic ability to heal. And how are we going to assess that? Well, we try to look at that through doing the laser Doppler blood flows. People have looked at histological studies as well. There's other ways. I mean, this is a study from Australia, and people looked at the ultrasound determination of rotator cuff repairability. So ultrasound assessment of rotator cuff repairability has sensitivity of 86%, quite high, specificity of 67, so you're going to get some false positives. The strong predictors of cuff repair, again, not rocket science, were tear size and age. So the bigger the tear, the older you are, the less likely it's going to repair successfully. And if the assessment of the tear size was more than 4 square centimeters, not just a length, but an area thing here now, and the anterior postural length was more than 2.5 centimeters, indicated an irreparable rotator cuff. So surgery cures it. Well, we're surgeons, and does it? Well, surgery is a major disruption to the normal life and work, visit to the hospital, physiotherapists, and and to say the cost as well. Here we have the NHS, but in Pakistan, there's a lot of people who have to pay for their own treatment. It involves significant input from different specialists. There's the physiotherapy, and then after that, we've already said there's a high retear rate and no effect on the clinical recovery. So which bit is the active ingredient? There are some good indicators. If we look at it clinically, if we're not going to be doing accurate blood flows, and I think the future is we need to be looking at the blood flow of the cuff non-invasively, and that's some work that is being done by radiologists around the world. Short history with obvious initiating cause. So somebody who's had a fall, we know that tear, the age of the tear. The problem we have when we go to repair a patient's rotator cuff, we don't know which part of the tear is repairable and is recent, and which part is chronic and has long given up the ghost. A patient relatively young does well, they're well motivated, they're compliant. A multi-center study from the States in 2015 done at all showed that actually the success of physiotherapy depended on the mindset of the patient. If the patient thought they were going to do well, they did well with physiotherapy. Again, not rocket science, so basic things. What are bad indicators? Well, old age, I'm afraid, loss of active elevation more than 3 weeks, little initiation course, slight jerk, so pseudoparalysis. If you're alcohol, people who drink, people who smoke, people who are non-compliant for whatever reason, and if they've had previous failed surgery, and importantly, anterior subluxation on resisted external rotation. So your anterior is straight, the cuff is so large now, the head is bald, that it's popping out. Doesn't mean no treatment though, and as Munawwar showed, we had the different classifications here, but this is well and truly fakuded, isn't it, Munawwar? So majority of pain can be resolved by regaining range of motion and stretching. Severe rotator cuff arthropathy here. So this is somebody who had a major cuff tear and absent cuff exercises. So these are deltoid strengthening exercises, which the patients can do, and they need to be motivated enough and told to stick with this for up to 3 months. And then there's the rehabilitation pyramid of recovery. And they can get a reasonable range of movement, weak, but good pain relief and function, able to do most of their activities of daily living. This is a severe rotator cuff arthropathy. I know we haven't got the time to go into things like, we've got reverse, we've got balloon arthroplasties and everything else, but thank you very much. I'm sorry keeping it short, but any questions?
Thank you. Are there any questions? Sir, we'll try to take questions in the end of the session if you are going to stay with us. Okay. I would like to invite Brigadier Khalid Masood. and he's working as the head of department hand and upper limb surgery unit, combined military hospital, and he's going to talk about alternative methods in cuff tears.
I'll just say, Khalid Saab, thank you very much for waiting, because you waited very patiently, but we are all waiting patiently to hear your talk, sir. You need to unmute yourself. I think you're... So we can see your slides, but you need to unmute yourself from your side. Or have you connected the mic? There you go. Now,
Walaikum salam.
Can you hear me?
Yes, sir. Just a bit slow, but you need to come closer to the mic here.
अब आ रही है आवाज?
बिल्कुल सर आ रही है.
Okay, thank you very much. Thank you, Mr. Munawar Shah, for arranging such a good session regarding shoulder. Or thank you, Tariq Zaman, for your very informative talk. और उससे पहले जो प्रोफेसर मोर्सी की टॉक थी वो that was again very informative and I like it. अब ये है कि मेरे लिए क्या छोड़ा है आपने?
आपके लिए मोस्ट इम्पोर्टेंट बिट छोड़ा है जो कि मोर्सी साहब भी रिपेयर नहीं कर सकते थे और आर्थराइटिस नहीं था जिसमें.
ये कि that alternative procedures for those that cannot be repaired. Sorry. So your theme was no cuff, no shoulder. I totally agree with this. That's why a lot of being done nowadays for the shoulder. So when to go for alternative procedures? Because when the cuff tear is irreparable, when you are not able to repair the cuff. So what is an irreparable rotator cuff tear? These are basically the torn rotator cuff which are retracted with a stiff tendon and muscle. And there is inability to contract with a force sufficient to rotate the humeral head ball on the socket. And when you see the X-ray, X-rays are like this. And in such cases, when the cuff is not repairable, my favorite investigation is the MRI. And on MRI, you can see the tendon that is chronically torn, the muscle involutes, and becomes replaced by a fat and scar. And this is seen on MRI as a white and represents a stiff muscle and doesn't contract. And healthy muscle, which is elastic and capable of contracting, appears as a gray on MRI. The grading system already discussed. And this is very important to manage such cases. Grade 0, there is no intermuscular fat. And grade 1, there are some fatty streaks. And grade 2, fat is present but less than muscle. And grade 3, equal muscle and fat. And grade 4, more fat is present than muscle. So grade 0, 1, 2, these can easily be repaired when such grading is present. But as grade 3 and 4 is concerned, then the repair probably is not possible. Then such cases need reconstruction. And patient presents in a variable conditions like severe weakness, and patient cannot raise the arm, mean functional loss, and may have severe pain. And treatment options in such cases is not the same. These must be individualized. So what are the treatment options left in such cases? These cases can be managed conservatively, and there can be reconstruction of the defect as well. And some cases need tendon transfer and may need arthroplasty, and some cases may need arthrodesis as well. Question is what to do and when to do. That basically depends upon two things. Already discussed, these are the patient-related factors and the local pathology. And what are the patient-related factors? These include age, severity of the pain, functional requirement. These are the main three things, but there is definite role of medical comorbidities and the smoking. Smoking basically plays the role for local vascularity. As the heavy smokers, they lose the local vascularity as mentioned by Tariq Zaman already. As far as local pathology is concerned, it is always important to know the condition of the calf muscles, already discussed. Whether there is a retraction or not, whether there is a fibrosis or stiffness, or sometimes these defects or these tears are related with nerve injuries as well. So in such cases, what should be the strategy? And there is also the importance of the condition of the joint. It includes glenohumeral arthritis and arthropathy as well. So then what are the indications of surgical repairs? Indication for surgical repair of massive rotator cuff tear vary greatly. These are based on the factors mentioned earlier. The acute traumatic massive tear, which are usually uncommon, these can be repaired primarily. But acute on chronic traumatic massive tear and chronic massive irreparable tear, these generally need reconstruction. What to do with chronic massive irreparable rotator cuff tear? And what should be management? Whether we have to manage the pain only, or we need the restoration of the function as well. That basically depends upon the presentation. Like this left side patient, the function is very weak and it is very painful. While on the right side, has full motion and minimal pain. So in spite of having massive rotator and irreparable cuff, whether he needs management or not. So in my opinion, the patient on left side, he needs management, while we can ignore the patient on the right side. So what are the treatment options? Treatment options can be the conservative management. These patients can improve with the arthroscopic debridement. And sometimes biceps tenotomy work very well. And there can be the arthroscopic or open allograft or cadaver tissue or xenograft can improve the situation. And sometimes arthroscopic partial repair give the reasonable results. And sometimes arthroscopic supraclavicular nerve release improves the pain. And sometimes they need augmentation, and sometimes they need tendon transfer. So the augmented devices can be biological, synthetic, and cellular. As far as biological preservation is concerned, one should be very critical about that. Basically, who is the candidate for biological preservation? For biological preservation or muscle transfer, The candidates are generally the young patients or the patient who need functional restoration, and they are associated with no comorbidities. And the condition of the glenohumeral joint should be excellent. And the objectives of biological preservation is basically that it should act as spacer, it should act as compressor, and there should be functional improvement as well, and it should stabilize the joint as well. And it is only done by the natural replacement, like the principle that like should be replaced by the like. So what are the options of biological preservation? Like this scenario, there is a loss of superior rotator cuff, retracted supraspinatus, and it is grade 2 rotator cuff tear, healthy muscle belly with nice excursion. How can we manage that? We should try to manage it with the repair. If the repair is not possible, then it can be managed with the direct repair, marginal convergence, or biceps augmentation. Or one can use the allograft for such patients. And what we do in such cases, we perform augmentation with fasciolata autologous graft. So the fasciolata is taken and double layer fasciolata graft is prepared, and we manage to repair the defect with the fasciolata graft. And this is the repair, or operative repair, and the final repair. And this is the operative coverage of the defect with the fasciolata graft. And the post-operative. Or definitely it is repaired with the metallic anchor suture, as already discussed. The metallic anchor suture, in my opinion, has better result for such procedures. Then there are certain prerequisites of fasciolata graft. There should be muscle belly, as already discussed, the condition of the muscle, that healthy muscle belly should be healthy one, particularly the supraspinatus and the infraspinatus. And there should not be fibrosis of the muscle belly, and there should be reasonable excursion. One must check the excursion of the muscle. So what about the loss of supra and infraspinatus? So we cover this with this graft and making two wings, superior and inferior, and taking it under the in the subacromial space, and the superior wing is managed with the supraspinatus and inferior with the infraspinatus. And this is the area, basically this is the area of the defect, and it is sutured at the footprint area. This is the poroperative pictures, and you can see this. Yeah, you can see the very nice movement and excursion.
Beautiful. Must say beautiful. Look at here.
So there is another scenario, a 50-year male with painful shoulder and gradual loss of function. And poroperative findings, we see the massive retracted tear. And in such cases, in this case, muscle is mostly fibrosed. And mostly replaced by the fatty tissue. It was grade 3 or 4. And there was very minimal excursion, or you can say almost no excursion. And these are the X-rays and the MRI. And arthroscopically, you can see this. So what should be done in such cases? That basically depends upon the presenting complaints, what the patient requires for that, and what is the requirement of the patient. Should we manage the pain only, or should we go for the functional return as well? If we are going to manage the pain only, whether the patient is having reasonable function or the patient is having minimal requirement of the function, then such defect can be managed with the allogenic dermal patch graft, or the superior capsular reconstruction can be performed in such cases, where graft is attached to the medial to the superior aspect of the glenoid tubercle and lateral to the greater tuberosity. Then the graft is switched to the infraspinatus posteriorly and supraspinatus anteriorly. And one can use the biodegradable subacromial spacer insertion. That is very common practice in UK nowadays. Or one can go for bar procedures. I think this is the favorite procedure done by the Munawar Shah. But as we don't have such facility here, what we do here? We use again the fascial graft and use it as a bar procedure arthroscopically. Here what we have this tunneler sort of equipment with us that can be passed subacromial through the subacromial space, and this patch is placed with the help of this tunneler under direct vision arthroscopically. Like this. And this is basically the graft, and it is passed with the help of this tunneler subacromial. And the sutures are retrieved. So one can, this is passed subacromially. Beautifully, it has covered the defect. One can see it. Then the sutures are tied over the acromion under the skin. So if the patient wants functional return, or there is a loss of function as well, then the answer is tendon or muscle transfer. So the principles of tendon transfer are: the transferred and the recipient muscle should have the similar excursion and tension, and transferred muscle should be expandable without compromising the donor site. The line of pull of the transferred tendon and recipient muscle should be similar. The transferred muscle should replace function of the recipient muscle. So the tendon transfer for superior rotator cuff loss, the latissimus dorsi transfer. Latissimus dorsi transfer is performed for such defects, and it is very good substitute to gain the function. And this is the general scheme of the latissimus dorsi transfer. And patients have satisfaction more than 70% with LD transfer, because it works very well when it is transferred in a non-functional or poorly functional shoulder. Then the LD can be transferred to cover the defect of the subscapularis as well. But in our practice, we do this defect to be covered with pectoralis major muscle because of the in the same area and with minimum functional loss. The transfer of the pectoral muscle generally improve the function and alleviate pain of the subscapularis area. And this is the scheme of the pectoralis major transfer for subscapularis muscle. And this is the pect major, and it has been transferred to the subscapular area. This is the post-operative picture. Then the tendon transfer for superior rotator cuff loss, supraspinatus and infraspinatus, and the use of trapezius. And many a times we use trapezius muscle as well. And you know that trapezius have three parts: upper, middle, and lower. So lower and middle, they can be used to replace the infraspinatus, and the upper to replace the supraspinatus muscle. This is the general scheme for augmentation of the trapezius muscle. And again, the fascia lata is a very useful graft for augmentation of the trapezius muscle. So used and taken and passed under the subacromial, and then this is the taken augmentation with the fascia lata and passed under the subacromial. It has covered the defect as well, and then sutured right at the footprint area. And what to do in nerve injury? Like this case, 42-year male, posterior dislocation, painful shoulder, inability to abduct the shoulder, and diagnosed with the massive rotator cuff tear with axillary nerve and suprascapular nerve injury. When there is a massive rotator cuff tear, when it is not repairable, and the muscle is also having the nerve injuries, and these both two nerve, these are very important, axillary nerve and the suprascapular nerve. And what to do in such cases? In such cases, again, what we take two sort of fascia lata graft from both sides, and one is used for the latissimus dorsi, and the second for the trapezius, superior trapezius. So these are augmented with the muscles and then passed over the defect and cover the defect and stitch there. Again, 52-year male, supraspinatus tear with fibrosed retracted muscles. What to do with the retracted muscle is fibrosed, but there is intact infraspinatus and subscapularis, and there is also axillary nerve injury as well. So for fibrosed supraspinatus muscle that is having a defect as well, it is covered with the transfer of levator scapulae. So the levator scapulae is transferred to the supraspinatus, and to overcome the axillary nerve injury, trapezius is transferred to the deltoid. So the levator scapula will take the work of the function of the suprascapular, supraspinatus, and then the trapezius will take the function of the deltoid. So these are again augmented with the fascia lata graft, and fascia lata graft is passed, and these are placed at the footprint area. What is our post-op protocol? Post-op protocol is the patient is placed in a custom-made shoulder abduction external splint for 6 weeks. And then the passive flexion and the external rotation is started after 6 weeks, and active assisted range of movement at 8 weeks, and gentle strengthening exercises started at 12 weeks. And progression to unrestricted activity at 6 months, that generally we take care of for another 3 months, and we allow the patient to do all these things after 9 months. So a prolonged dedicated therapy program is required after surgery in order to train the tendon to function properly. The gains from tendon transfer procedure may take up to 1 year to realize. So in conclusion, management of massive rotator cuff is difficult and tricky. Lot of options are available with variable results, but biological preservation has long-lasting results up to the entire satisfaction of the patient and the surgeon as well. Thank you very much. Any question, please?
Thank you. Thank you very much, sir. Thank you very much.
As usual, Brigadier Saab, a very, very entertaining and very, very nice talk. I'll just give a short history of my experience. When I first started orthopedics, the only transfer I was doing was pec major transfers when I was doing shoulders, and when I did a total replacement or a reverse, and then or a hemi actually, and there was a question about the subscap, I do the pec major transfer. But I learned from Brigadier Saab a lot, and I've started in my practice. We have a breast surgeon who does lateral side transfers to fill up spaces, and I worked with him, and together we've done 4 or 5 of my shoulder cases and 4 or 5 of his breast cases, but we work together, so we now have got very efficient graft taking techniques. The other thing that I want to say is that you know, Hamata, the original guy who, not Hamata, what was his name, Sufyan? The guy who did the first SCR procedure, the Japanese guy, he started with tensor fascial lateral grafts. I don't know who convinced him to go to the artificial graft, and he spoiled the world. Mahata, that's the one. He spoiled the world, and now everybody wants to do artificial grafts with skin from porcine or calf. But the original graft was always tensor fascial lateral. I think tensor fascial lateral has got a lot of uses. I'm very comfortable doing lateral side transfers, and I'm very comfortable doing pec major transfers, but I've not tried the other ones yet. I am not skilled as good as Khalsa, but yes, you know, kudos to you, sir. You've done really well, and you know, long may your techniques live. I think now is the time, sir, for you to write a book. You need to get some of your juniors to help you, and maybe Hasid can find somebody for you. You have to write a book, sir, because for people like me in the future, we need to know how to do this.
Sure, inshallah. Sure. Thank you very much.
Well,
Any questions from the audience?
There's also the technique that you described with the terrible nerve injury, and you did the transfer distal to the elbow as well. I mean, that's a new one, really, so that needs to be written up. I think you showed us the patient when we were in Lahore, or showed us the technique when we were in Lahore with the major brachial plexus injury. Hello?
Yes, hello?
Yeah. No, just saying you need to write those cases up, sir. That's very important.
Inshallah, I'm working on it. I'm writing on it. Inshallah.
Sir, one question from Khalid Saab. Sir, how frequently do you see these suprascapular nerve entrapments?
Suprascapular nerve entrapment, basically the patient who present to you with scapular fractures, most of the time they have suprascapular entrapment. Generally, in normal cases, I have seen very few suprascapular entrapment, but most of the cases who present with the fractures, they always have suprascapular. Either they have suprascapular injury, or they have suprascapular entrapment.
Aseeb, can I just say, there's a article just published from Gerber Center in Belgrist in Zurich, and they did a prospective trial of releasing the suprascapular nerve in rotator cuff repairs, because it's something that, you know, LaFosse and all these people have talked about. And he actually stopped the trial because he found that the only thing he was finding was that in about 2 or 3 patients, they actually caused a nerve injury with the post-op EMG studies, not having identified. So they've stopped it. He doesn't advocate it at all. You know, I mean, what Brigadier Saab is saying, that's a different thing, scapular injuries. But in normal rotator cuff repairs, etc., there are some people advocating the chronic retracted ones. You also release the suprascapular nerve. But Gerber et al., they stopped their prospective trial because they were finding all they were doing was causing some temporary damage to the nerves that wasn't there before.
Was Gerber and Tarek doing them arthroscopically or open at the same time?
Arthroscopically.
Because Lauren Lafosse, now his son, I don't know what his name is, they're both advocating that if you do a cuff repair, you should do an arthroscopic release for everything. But yeah, you're right. I mean, you know, in my personal experience, which is not a lot like this, I have not seen many suprascapular nerve problems. Very few times that there is a cuff is intact and I go in there and I find nothing wrong with it but nerve function. And then when I've done a nerve conduction study retrospectively, I found that maybe 1 in 1,000 or something like that, because I don't see many like it. Very rare, very rare.
They use the Naviser portal for trying to get in at the top.
Yes, yes. I don't release them anymore. I'm too scared now.
Well, you know, I mean, if it's not causing any benefit, what's the point?
Exactly, yeah. So anyway, sorry, I say, can we wind it up, because a lot of people have been very patient. We've been hijacked by a group of surgeons who were surgeons, because I believe this was explored or posted on one of the Indian forums, a few of the Indian forums. So this is what we get. So in the future, please, we can leave it local. Otherwise, people for no reason at all want to do various stupid things to us like that. But you know, everybody was patient. At one stage, we had 36 people in the forum, which is an amazing number. And you know, we are now ending 2.5 hours later, 2 hours later, and we still have about 13 to 14 people in the forum listening to all of us. So thank you very much for all your patience. Thank you, Khalid Sahab, for waiting patiently, because as usual, they put the best to the last, like I say, you know. And can you thank Professor, you know, from Egypt, Hasid, for his presence, and maybe hopefully we'll ask him to come and talk again, yeah. But thank you very much, and hopefully we should do this a lot more.
Thank you.
Should we close the meeting?
Yep.
There is a video in it. I will edit it and take all the naughty bits out of it, and then I'll post it to all you guys like we're
Well, you know, the half that I've left were all Indian anyway.
Were they?
The half that I've left were all Indian.
I think the Gurki group has been very kind to us. They've you know, with sort of met us and have with their full hearts have enjoyed and contributed. And also the forum that I teach on, you know, there's quite a lot of people from there. Unfortunately, this was targeted to the arthroscopy doing people in Pakistan. Unfortunately, for them, politics is far better than education anyway. So let them live their lives and we'll live our lives. You know, I've got nothing to do with them, and I'm sure they have nothing to do with me. But hopefully, we will continue this, and we will hopefully have more education. Yeah.
Inshallah.
Okay. Thank you very much for everybody. Yeah? Thank you, Steve.
Thank you, sir. Thank you, sir. Thank you all.
Steve, if I give the videos to you when I finish them, you can pass it on to everybody then, yeah?
Okay, sir. Okay, sir. Sure.